Well, good morning, good afternoon, and good evening to YPOers and friends around the world. Welcome to this global conference call webinar of the YPO Psychedelic Medicine for Mental Health Group. We've got a really exciting program, and we're doing some new and different things today. As background, the Psychedelic Medicine for Mental Health Group has been leading various webinars and global conference calls over the last several years to allow members and friends to learn more about the really exciting space and potential of psychedelic-assisted therapies to make a huge difference in the wellness of people who are otherwise suffering and could be leading a much more promising life. There are exciting new developments in the space, and one of the areas that's really important is, all right, it's a great idea. The data at this point looks very promising. How are people actually going to be able to access this? Some in this audience, whatever the cost is not going to be a barrier. But for the vast majority of people, these are intensive therapies with huge promise, but that cost money to do. So today we have a very, very exciting panel. And this is a first for this series where we're actually having two members of a panel, and we'll be doing a fireside chat to discuss this. So the topic for today is reimbursement and essentially how to make this amazing potential of healing available to large numbers of people. Let me give you a little bit of background on the panelists, and then we'll introduce, and then we'll begin the conversation. Throughout it all, if you have any questions, comments, whatever, please put them in the chat. The plan is that we'll spend some time in this fireside chat, and then we'll shift over to address questions and comments from the audience. So please submit those in the chat box. So first, about Mike Cotton. Mike is a veteran managed care executive, and over the course of his tenure as COO at Meridian Health Plan, which is a multi-state managed care provider, he focused on continuous improvement, efficiency, and population health strategies that emphasize better patient outcomes. Over the last several years, Mike has been very involved in making huge progress in making this care accessible to a broad range of people. So Mike, welcome and thank you. Also, Rais is joining us. Sherry is the CEO and co-founder of Anthea. Anthea is the first organization to offer employee benefit plans for psychedelic therapy, and they're starting with ketamine therapy. In addition to being Anthea's CEO, she's the executive director of the Boston Psychedelic Research Group, an advisor to the California Institute of Integral Studies that runs a very important training program in this space. And I've known Sherry for many years, an amazing individual. So we have two incredible people gathered here today to join us in this conversation. So can each of you, Sherry, can you start off by providing an overview of what psychedelic therapy entails and the types of conditions that it's currently being used to treat? And welcome, and thanks for joining.
Thank you so much for having me, Dick. At a high level, what psychedelic therapy entails, for those who don't know, is the use of a psychedelic substance. Now, there are many psychedelic substances out there. The ones that are gaining a lot of attention are MDMA, commonly known as ecstasy, and psilocybin, also known as magic mushrooms. Ketamine is another one, and there are many other psychedelic substances, but it's the use of one of these substances in combination with therapy. So it's not taking a drug alone, it's not doing therapy alone, but it's the combination of both, which is really a unique treatment model. And the process involves preparation. So before even taking any kind of substance, you would work with a therapist to understand what your intentions are and why you're here and why you're doing this. You would then have a number of medication sessions, depending on what your therapist believes is best for you. It could be 1 to 6 sessions. And following these medication sessions, you'll do what's called integration. So you will work with a therapist post taking a psychedelic substance and sort of try to integrate the lessons that you learned while you were in an altered state, so that they lead to real profound change and lasting change. And actually, the evidence is quite remarkable in terms of the indications this is being used for. We've seen a lot of great results for PTSD and treatment-resistant depression. We've also seen, depending on the compound, some really great results for anxiety, social adjustment disorder, addiction and substance abuse, eating disorders. There's quite a long list of behavioral mental health conditions that psychedelic assisted therapy could help people with.
Great. Thanks, Sherry. Mike, if you have anything to add there, if not, why don't I
No,
ask
I
you?
don't think I have anything to add. Yeah.
All right. How does the current legal and regulatory landscape affect the accessibility of psychedelic therapies for patients?
Well, yeah, I mean, I guess sort of the very basic answer to that is that most of these are still illegal and there's no, federal approval, FDA approval of any of these medicines with the exception of ketamine. Um, so, that effectively makes them, inaccessible with the exception of, Oregon, which created a state regulated program, and then clinical trials. And there's been a few states that have also created kind of their own studies as well. So yeah, I mean, I think the bigger I think accessibility issue is going to become in the, sort of the practical application once there is federal approval. The medical system is, fairly complex. It'll be a new practitioner, new type of a completely new style of therapeutic, like doing a medicine with a, psychotherapy combination that's figuring out how that is going to be implemented, have enough therapists, space to do it. What is the cost and outcomes that are still sort of in their nascency, I'd say, in terms of kind of what we know for outcomes, and clinical trials can often be optimal settings. So insurance, typically will want to see more evidence of how this can work before they're, really accepting that, yes, this is, worth paying for and the protocols are kind of set in stone. So yeah, I mean, the Schedule 1 for these drugs has left them, unfortunately unavailable for a very long time. And the stigma of being illegal and being more party drugs, certainly becomes its own hurdle in terms of like mainstream medicine adopting these.
So, and in terms of evidence supporting the efficacy, what evidence exists at this point, and how are these outcomes influencing insurance providers' willingness to cover these treatments? And maybe we can start that with Sherry, and then Mike, turn that over to you.
Yes, so the evidence in clinical trials, particularly for conditions such as PTSD and treatment-resistant depression, has been quite promising. Generally speaking, depending on the study, we see anywhere between 60 to 80% of people who participate in a clinical trial using psychedelic assisted therapy no longer presenting the conditions of their original diagnosis at 12-month follow-up. We don't see that kind of result with really anything else in the way we treat mental health. What that means is, let's say I have treatment-resistant depression and I did psilocybin-assisted therapy. At 1 year follow-up, 60%, or there's a 60% chance you could say that I will no longer present the conditions for that treatment-resistant depression, which is really remarkable. Currently, ketamine therapy is the only psychedelic treatment with some level of insurance coverage because of its FDA approval for certain conditions. And insurance coverage for ketamine therapy varies, with some insurers covering a portion of the cost, some covering a little bit more of the costs. We can use health savings accounts and flexible spending accounts at HSAs and FSAs to manage some of these out-of-pocket expenses. But as MDMA and psilocybin near FDA approval and more data is shared, there's a greater likelihood of insurance carriers covering these treatments. And for MDMA, the application for FDA approval has been submitted, and we're looking at hopefully approval this August.
Yeah, I mean, I think just to build on that, I'd refer back to, I still think there's I don't have a crystal ball, obviously, in terms of kind of how well the insurance industry is going to embrace these, but typically, new types of treatments coming online, and with at a certain expense level, which this one is certainly would meet a threshold of being on the expensive side, and the complexity of how to administer the benefit is going to create barriers. I mean, to get a little bit in the weeds on how insurance companies work, it's essentially going to be reviewed by two different organizations. When you look at like the pharmaceutical application, and then looking at how does the medical treatment, therapeutic treatment, behavioral health side work. And in many cases, actually, with insurance companies, they actually do farm those out to two different organizations. And so, the coordination between those two becomes pretty critical. And then you've got the expense of the drug and the expense of the therapy. So, there's a good chance that they're going to throw up some barriers to coverage, and maybe, requiring people to do other therapies first. And so I bring all that up because it becomes more and more important that as much as we can collect data on outcomes and effectiveness, that becomes the story that organizations like Anthea can go and pitch to both payers and employer groups to say these are worth covering, because look at, we were able to eliminate their PTSD, but really like learning what cost avoidance is there, could you avoid all these ER visits, these medications, all these additional treatments. And there's some of that in these clinical trials, but not, it's not typically what clinical trials are looking for. And so you kind of need these practical organizations to take a chance on, either building pilots. You've got forward-thinking employer groups that will pay for it, and really collecting that data to prove that, even as these are applied in real-world settings, the outcomes are incredible and they're worth covering.
So using the forward-thinking employer comment, Sherry, could you speak to, because this is the group that you are working with, can you like briefly lay out what it is you're doing, and then what the main challenges are in obtaining insurance coverage and reimbursement for psychedelic therapies?
Yeah, so what India is doing is, because major insurance carriers are not broadly covering ketamine-assisted therapy, or honestly not really covering ketamine-assisted therapy at all, what India is doing is we're making it easier for employers to add this on as an ancillary benefit. It's kind of similar that how you would add dental or vision plans to your employees. And we are making it seamless. We are providing a lot of education and onboarding to employers, and really talking to employers about the benefits of offering something like this to their employee population, even from an employer perspective, in terms of lost productivity, absenteeism, retention issues. We see in the US that the treatment of mental health costs employers just over $200 billion a year. And then the indirect costs of all of these mental health issues on employers is actually $500 billion a year in terms of retention and what it costs to rehire people. So this is a huge issue. And unfortunately, right now, 2/3 of US employees feel that they're not getting the mental health care that they need. They experience super long wait times. Even when they can see a therapist, there are often complaints that they're not feeling better over time. They're having to stay on antidepressants for years, if not decades. This comes with a lot of side effects. And so everything we are doing right now is really just kind of putting Band-Aids on, rather than getting to the root cause of people's trauma and illness. And so again, India is changing this by just offering supplemental benefit plans that employers can add on. And hopefully the insurance industry will follow by seeing the desire and the demand from employers for this coverage, by seeing more and more clinical data, by seeing a change in public perception. The goal is that insurance carriers will follow and will cover these treatments.
So, Mike, can you speak just a bit? I guess there are two questions here. One is around if it's an insurance company that is going to own the patient liability for the next year, the economics are very different potentially than an employer who is trying to have productive, happy, effective employees over an extended period of time. But how does the cost of psychedelic therapy compare to traditional treatments, and what implications does this have for insurance providers and patients?
Yeah, I mean, it's a little complicated of an answer. I mean, I think the medicine side of it, while sounding expensive, could be several $1,000s for for the total protocol if you're, looking at MDMA specifically, at least, because that's sort of, I think if we're going to look at protocols, that's the one that's sort of most developed. I think ketamine, in fact, is sort of it's a lesson learned in terms of, what really needs to be done to kind of lift up this ecosystem and make sure that it's more broadly covered and understood. It wasn't particularly organized with ketamine. You didn't have real standards of care around it. The sort of outcomes and information available were thin, and so it took several. You are seeing Spravato uptake now, despite being kind of expensive. It actually is starting to be covered after several years on the market, but it's not in a way where we think we're starting to see what's the most effective, and that is having a protocol that's paired with psychotherapy. Now the psychotherapy piece is the part that really starts to get complicated, because traditionally insurance just does not pay very well for mental health services, and that's sort of the sad fact. And in fact, even just going beyond insurance, we've as a nation really kind of invested in our mental health systems, and you've seen lots of closings of mental health hospitals, clinics. State community mental health systems are always struggling for funding, and so you now have what we're seeing is a really effective treatment protocol, but the psychotherapy is so far beyond what insurance companies are used to paying that, I mean, by hundreds of percents, multiples over what they typically pay. And so that, presents a very real hurdle for, insurance companies to sort of, reframe their thinking there. And again, I'll go back to that is the importance of speaking with data and outcomes, because, I mean, you mentioned the difference between employer groups and insurance companies. Certainly in the government program space, which I'll acknowledge is very different from the commercial space. And I think we'll talk a little bit about that later, but there are, there are certain requirements for insurance companies to, be looking at. Like, you have to, you want to reduce the number of ER admissions, readmissions. You have requirements for being able to connect and get people into care after inpatient admissions and things like that. And so, I think if we really, are seeing what could be a very, strong protocol for treating trauma, and which is a lot of reasons why people are kind of, accessing the medical system in kind of unstructured ways and ways that insurance company doesn't like to see. If we can start to build data around that, it will make it more likely that insurance companies are interested in paying for it. And yeah, I'll leave that at that for now.
I think I'll just add something there if that's okay, Mike and Dick. You brought up some really good points, Mike, especially around Spravato. So Spravato is the only ketamine that is covered by insurance carriers. I probably misspoke when I said insurance isn't covering ketamine. They're not covering generic ketamine, but they are covering Spravato. Spravato is literally 100 times the price of generic ketamine. So a dose of Spravato is $1,000, and a single dose of generic ketamine is $8 to $15. There's a really huge price differential. And then, as Mike pointed out, with the therapy component that's needed in ketamine-assisted therapy, that therapy component is usually not covered by insurance. So we have this huge problem here. And I think, as Mike pointed out, just having data to show patient outcomes, having more policies in place, a legal framework, and as well as like standards and training, so standardized protocols and trained therapists, and ensuring proper standards for training is crucial for insurance coverage. But one thing I do want to highlight is just how strong the evidence is for ketamine assisted therapy. I see Marnie has joined us on screen, so she can share a little bit probably about that too. But what we're seeing is ketamine is the only substance that's known to reduce suicidal ideation in 4 to 6 hours. It creates an 89% improvement in mental well-being. From Anthea's members that have gotten covered with ketamine assisted therapy and treated, we saw at 1 year follow-up, 82% of them were no longer on antidepressants. So there's really strong evidence here and incentives for insurance carriers to cover this.
And sorry, just one last thing I'd want to add, that Sherry kind of mentioned something that reminded me. I mean, as employers, and certainly self-insured employers, but employers as a collective group, it's actually a very powerful, advocacy system that can demand more from their payers. And there has been some regional work. Unfortunately, healthcare is very regional, as I'm sure most people on this call know. You're not, what it costs in one region is vastly different from another, and you're really looking at who are your local providers. But regionally, there actually has been some success of like gathering like business association groups and advocates and payer groups, and really demanding more on the behavioral health side, and demanding that insurers, increase their rates, because there is sort of this, canard, like a red herring, that insurers say, oh, well, over 50% of behavioral health specialists don't accept insurance. So, sorry, we have such a poor provider network on your behavioral health side, but over 50% of them don't accept insurance because they pay so poorly. So it's like this self-fulfilling prophecy that, that traditionally nobody's really done anything about. And there has actually been improvements, at least at a regional level, where there has been organization and demand for better behavioral health services.
So, Mike, can you expand a little bit? Because you've done a lot of work in the whole area of equity issues and challenges with access in this space. What are kind of your thoughts on that, and how that might be addressed over time?
Yeah, I mean, look, this is a huge issue that goes well beyond psychedelic therapy, but it's certainly one that's really important to me, and where I kind of spend most of my time thinking about. Having operated within, my family managed Medicaid programs mainly across the Midwest for 20 years, and managed millions of members' benefits over that time. So I had a lot of experience dealing with low income, low resource communities, marginalized communities, Black and brown communities, LGBTQ, the ones that have outsized poverty issues, and just the lack of the delivery system being fractured, payment being really poor, resources just not even being available. As I said, these mental health institutions that they traditionally go to, community mental health and such, are deeply underfunded. So it's, the knowing that this is a real access challenge even for the commercial markets, that now you start to look at Medicaid and some of the indigent markets, and you can, as you can imagine, the problems are incredibly compounded, both just from social factors, but then also the medical system itself. Are we actually going to get enough therapists? Where are they going to be treated? And will the low payments that Medicaid does pay, because that's how Medicaid works, it pays less traditionally than commercial. Will people accept payment? And so myself and a couple of other philanthropists in the field, and then actually several more now, have supported the effort, started the Psychedelic Health Equity Initiative. And we're really starting with the data component, and actually, we need to, what goes on in these clinical trials is typically these same people that are left out all the time are left out of those too. They're, often don't have the time or resources to participate in clinical trials. And so we just don't have enough data, and which then translates to insurance companies are going to have additional skepticism too. Oh, this is a very expensive thing. We don't know that these people that traditionally have job instability and housing instability, homelessness, substance use disorder, all these comorbidities, outsized mental health comorbidities, is this even going to be effective? And it's also very expensive, and we have very little data. So, we're really working on building out a cost effectiveness kind of healthcare information set, so we can really, how can we, we're going to start pilots where we're actually treating the communities we're talking about, and setting up so that we can actually collect the data. What's it going to cost? How can we, what do the clinical models look like? And including these sort of community support systems that are traditional in health equity, knowing that, often these people will not have the resources to go on to continuing integration support specialists and psychotherapists. So what are peer support systems that need to be in place? Community organizations. This is really looking at community models. We've got some pilots that I think are going to be really exciting, where like local ministries are involved and want to be part of the care continuum, and things like that are going to be really important for these types of low resource communities. And so, we're really, I think, the only organization that's, there's, some research that's happening here and some things going on kind of disparately, but we're really trying to look at, how do we treat these populations? What does a clinical model look like? What's it going to cost? What are the supports that are needed? And just start collecting that data, because it's going to be really critical to see what those outcomes look like. And then what that translates down, I mean, these are long-term efforts, right? These are just getting the therapist, getting the space is going to be a really long-term effort. But down the road, having enough data to really go to HHS, CMS, like really start to unlock government funding to support these, because you're talking about communities that traditionally have the most trauma and the highest rates of depression and suicide, and dealing with, all these social demographic issues that are, much worse than a lot of the population. So these are, in fact, the people that probably could use these life-saving medicines the most and will have the greatest barriers. And so we're really trying to focus on removing those barriers and really collecting the data. And happy to drop into the chat, some contact information for people that are interested in learning more about it, because it's it's obviously a philanthropic effort at this point. And we love the support, and I think it's it's sort of incumbent that we really do better job and be intentional about helping these communities, because we just know that traditionally, if we aren't intentional, they're going to be left behind.
And what Mike is doing in the Psychedelic Health Equity Initiative is incredibly important. And, from a front row seat, he's doing an amazing job of addressing that really important issue. So, Sherry, can you comment on the potential impact of psychedelic therapy for patient health outcomes and overall well-being? And then more specifically, how offering coverage for psychedelic therapy can benefit the employers in terms of employee health, productivity, retention?
Yeah. So one, to start off with the patient outcomes, I can speak to real outcomes and not just the potential with what we've seen so far with ketamine-assisted therapy. What we've seen with ketamine-assisted therapy when we did a pilot study was, in 1 year, 86% reduction in PTSD symptoms, a 67% reduction in depression symptoms, and a 65% reduction in anxiety symptoms. We also saw, as I mentioned before, that 82% of people that completed the ketamine treatment were no longer on antidepressants at 1 year follow-up. Now, for self-funded employers, just from a cost perspective, the cost of completing a full course of ketamine-assisted therapy treatment, depending on where you're going and how it's administered, can be anywhere from $2,500 to $8,000 for a complete treatment. That's sort of a once-off cost. You don't do it every year. Whereas the ongoing cost of medication plus talk therapy for a self-funded employer is about $10,000 per employee per year. So you see about a $25,000 in savings in 3 years for an effective treatment, which is a huge cost savings to employers. And then beyond the direct cost savings from medical spend, we see that, not we, SHRM, the leading organization that looks at HR data and employers across the US, has reported that employees that feel their employer actually cares about their mental health are 79% less likely to look for a new job, 3 times more likely to be engaged at work, 71% less likely to report experiencing burnout, which is actually the #1 reason people leave their job right now, 36% more likely to be thriving overall in their lives, and actually 5 times more likely to advocate for their company as a place to work, just by taking care of their mental health. We also see that in terms of productivity, people who are experiencing depression are unproductive 35% of the time. And 62% of the times that they're missing work is actually due to mental health. So there are tremendous savings and benefits to employers, and we're already seeing the patient outcomes with ketamine-assisted therapy alone. And based on clinical trials, we anticipate even greater positive outcomes once MDMA and psilocybin are approved, and those are offered to employees as well, especially in treating treatment-resistant populations. And one thing we don't talk about enough when we're talking about mental health is that 30 to 60% of people who are experiencing a severe mental health issue like PTSD, depression, anxiety, substance abuse are actually treatment-resistant. So we keep throwing things at people when there's a pretty good chance that it's not going to work on them because they are treatment resistant. And the unique part about psychedelic therapy is that it's one of the few things that we've seen works with treatment resistant populations. So that's really exciting for employers as well. And I won't keep spewing off more data, but the last thing I'll say is that in terms of disability claims, this is like another huge area of interest to employers because the number one reason for disability claims is actually due to mental health as well.
I would say that the aggregate of the data, in addition to each specific piece, is an incredibly compelling return on investment, if you will. Forgetting about, which obviously no one would want to forget about, the incredible difference in human quality of life and alleviating suffering. It's just a good business decision also. Mike, from your experience in managed care, how do you see this integration of psychedelic therapy into mainstream healthcare models actually evolving?
Yeah, I mean, I think about it from a couple of different perspectives. I mean, for one, I mean, if just like the pure adoption standpoint, like if you think about organizations like Anthea, I think those, it's important to proliferate that kind of thing. I mean, there's lots of specialty organizations in the healthcare field that sort of, pitch their services to the big, large insurers or to employer groups. And they kind of get this specialty niche and expertise, and then they can go out and proliferate it. And so I think for quite some time, those types of organizations are going to be really important to the space and really important to getting these kinds of services paid for people, because insurance companies are typically risk averse. All the things that we've already kind of said here about why it's going to be challenging for insurance adoption is going to happen for some time. Now, there may be some that adopt in some areas, but then I will also say that insurance companies don't love being the only one that's offering benefits in a certain region, because then they get worried about adverse selection, and that means people are going to look for these insurance companies because they will pay for it. And they don't love that people seeking for services to be paid for. And so I think, again, like this is an early in the life cycle, cutting edge organizations that can collect this data, do a good job of pitching it to employer groups and insurance companies are going to be really critical to spreading out reimbursement for this. And even as I think it becomes more, eventually it will become more mainstream, the data will prove out. As I'm a big believer that the data is going to prove out over time that these are absolutely worth covering. Even as insurance companies, and some of them will take it on in-house, but still often, I mean, things that have, types of services that have been around for years and years, they still farm out to specialty organizations because, in the large picture, if I'm United, that covers millions of people, like PTSD, for example, isn't necessarily something that I'm going to commit a ton of resources to build out networks, oversee protocols and things. They're going to say, oh, here's a specialty group that's really good at it, knows how to do it. I'm just going to pay them to do it. And so, I think those are still important. I think there's also going to be an evolution of, how this gets paid for. I think, I've spoken with groups like Lycos and MAPS and USONA and others, and, talked about, sort of the likelihood of insurance reimbursement and what's the best pathways. And I wish it could immediately start out in sort of a value-based design, sort of like, here's a protocol, this is what it costs to treat this, and these are all the services sort of that encompass that. And I think it makes it a lot cleaner and easier for insurance companies to, say, oh, I'll pay for that. But when something's so new, they're really hesitant to do stuff like that. And so, often a lot of these services will get parsed up. We'll pay for this and, maybe this, and then we'll see how it goes from there and we'll pay for that. And so I think you're going to see this sort of, be a chunky kind of reimbursement that's not necessarily the most effective way to execute on this protocol. But I think over time, we're going to see the costs kind of become more sophisticated and probably come down too.
Great. Thanks. Sherry, I'm going to give you one question, then I'm going to turn to Marnie for a moment, and then we've got a lot of questions that have come in from listening, people participating. Can you just overview of how Anthea is pioneering insurance coverage for psychedelic therapy?
Yeah, I will be quick with this one so we have enough time for audience questions. But really, we saw that since insurance carriers are not covering generic ketamine and not covering as a whole ketamine-assisted therapy, like the therapy component, we spent and also because we saw that since this is a nascent industry, there didn't exist the standard protocols and credentialing processes and things like this throughout the country in order for insurance carriers to offer this. So what we did is we spent years building it ourselves. So before even going to market and working with employers to offer ketamine-assisted therapy as an employee benefit, we spent a few years, actually, Mike helped us a lot with that. So thank you, Mike, building protocols, standards of care, a credentialing process, and a network of trained, vetted providers. Marnie is included with her practice in that network. So this is a nice full circle. But what we are seeing is that for your average person, a really important service is actually knowing where to get safe treatment. If you were to just Google ketamine therapy Boston or ketamine therapy New York, wherever you live, you'll actually see and get confused, the average person, because there will be so many ketamine infusion clinics that don't offer therapy in combination with the ketamine. There's actually a huge growth in this market. There's over 1,000 clinics all over the US, which is a really large number considering how new all of this is. And so we helped create a trusted, vetted provider network so that when we work with employers to offer this as a benefit and to cover it and make it affordable, we're also offering safety so people can count on standards of care and a network they can trust.
Great, thank you. And with that as a perfect segue, I've invited to join also to talk about something really interesting that she's doing. She's doing a lot of interesting things, but in particular, way of providing access. Dr. Marnie Chanoff, who's the founder and CEO of Joy in Health, who's a Harvard-trained psychiatrist. She's on the faculty at Harvard Medical School and McLean Hospital. She practices and teaches integrative psychiatry. She was trained at Harvard, MGH, and McLean psychiatry training. She's received multiple awards and trained in ketamine-assisted psychotherapy. Marnie has come up, and she's created and is running an organization called Joy in Health to inspire and empower people to work toward their health goals. Marnie has been very interested in this area of equity and has come up with a unique partnership and a unique way. Hopefully, ultimately, the work that Sherry is doing will have massive number of employers offering. The work that Mike is doing will have large institution, government and other larger insurer institutions. But today, now, Marnie, can you share what you've come up with as a way that practitioners or groups of practitioners working with philanthropists can make a huge difference in people who today need access and can't necessarily afford it?
Sure. So what we have decided to do is partner with an organization called Thank You Life. They're a nonprofit organization committed to accessibility. And they started just even a few months ago. This is really new. They reached out to us. We have been in their network hoping to be able to engage with them as they've raised funds, a general fund to support ketamine-assisted psychotherapy. But they reached out to me a few months ago, maybe just 2 months ago now. And what they have decided to do was allow individual practices to raise their own funds to support CAP work for people in their own community. So it's beautiful. And I said, absolutely, sign us up. And so what it is, it's a giving channel so that philanthropists can give tax-deductible donations through Thank You Life, which then get put into its own bucket for a specific practice or center or clinic that is already partnering with them. They've already vetted you. They've already know the quality of your work and your vision. And the practice can then raise funds. Hopefully they're able to do that through their networks and take those funds and set them aside for people who need ketamine-assisted psychotherapy who wouldn't be able to afford it otherwise. And if those people who are applying for that scholarship through that funding qualify based on need, then that money gets then sent to the practice for care. So that's what we've decided to do. So we set that all up. And there's this giving channel that we can hopefully access to contribute to this. As a practice, what we have decided to do is for those people who will receive the scholarship, we are going to reduce our fee by 50% in order to also meet the need of our community. And we're in the process of figuring out how many people we can do that for, how often, how many people at a time. But it feels like a way for it to be kind of a multi-pronged approach to increasing accessibility here in Boston.
Which is an absolutely great thing you are doing. And I'm all the time getting questions from philanthropists around, all right, policy change is important, for some legalization is important, et cetera, et cetera. What can I do to help today? And this type of partnership, be it through Joy in Health, if you're local in Boston and interested, but wherever it may be, is a phenomenal way of providing access to people who unfortunately will not be able to qualify as an through their employer because often they may not be employed, and it's going to be a while before Mike's incredible efforts that I support and advocate and think are amazing, can bear fruit, for somebody who's suffering tomorrow. So, Marnie, thank you so much for what you're doing and for your commitment, reducing your fees by 50% there. So we have a lot of questions here, and I will try to get to some of them. One is, can the Mental Health Parity Act be amended or improved such that it'll actually work as intended, or as originally envisioned, or does it just something completely new need to be handled? And Mike, that would
Look,
be
it could obviously be better. I think, trying to reopen laws and get something passed at a federal level is a real it's a real heavy lift. I've been involved in some of those efforts, and I know, even for some very small things, it's really complicated, and which is why most people have given up on the government. But I will say that there is hope there. I mean, I think it was last year, the Parity Act finally did get some teeth into it with regards to holding, insurance companies accountable for how they're applying utilization management efforts on behavioral health versus physical health decisions. And for years and years, it was kind of a joke, like you were required to not treat it any differently, but the government didn't really do anything about it. And they now actually have the abilities that kicked in, as I said, pretty sure last year, where they can now request the information. So if you are a patient or member of an insurance plan and you feel like they are treating your behavioral health authorizations differently As a patient, you are allowed to request through Department of Labor, maybe that handles that piece of the mental health parity, a review. And now they are actually conducting reviews of health plans in there. It can get really intense. Health plans do not want to do it. It's a lot of data they have to provide, and then they can get in real trouble now in terms of, if evidence is showing that they're treating behavioral health decisions differently than physical health. So that's a real sea change that has come. Now, I think there probably needs to be a catch up of people understanding that that's there now, but I think that is a really big deal, and more people need to know about that.
Great. Thank you. Thank you very much. The next one that came through, and this was not a setup question. This was a legitimate, a real question. A person close to me has regular ketamine treatment. Not sure of exactly how frequent, but I believe it's regular. It costs a lot. He's the CEO of his company, and I believe has great health insurance via a major insurance provider. What options do you believe are open to him? Sherry, do you have any ideas on this?
Promise it's not a setup question.
It
Yes.
is not. We're not identifying questioners, but I promise it is not.
If anyone close to you is paying out of pocket for ketamine treatment, and they're in a position to maybe get this covered at their place of work, they can reach out to me at sherry@anthea.com, or go on our website at anthea.com, and we're happy to work with employers to offer this as a benefit and help get them coverage so they don't have to pay out of pocket. But also on the other thing of this person is working with Blue Cross Blue Shield. Depending on the size of the employer, if the employer is large enough, we can actually integrate with the health plan directly. So if it's a self-funded employer and there's enough employees, they can actually go to Blue Cross Blue Shield and say, hey, we want coverage for ketamine assisted therapy. We're paying for this as a self-funded employer, and Anthea can work with Blue Cross Blue Shield or whoever it is, Kaiser, United, doesn't really matter, to partner with them to offer this coverage via the health plan.
Great. Thank you very much. A question, and this is directed at you, Marnie, but it's a broader question, if you will. I love what Joy in Health and Thank You Life are doing. How are the scholarship recipients being chosen? And they full scholarships or partial ones? And how are you thinking about it? And I know that it's fairly early in the process, but this is like, again, you and some others are doing really groundbreaking work. So how do you think about that? Marnie, you're muted.
So we're going to approach this in a very individualized way to start. And we will invite people who otherwise couldn't afford to pay for it to reach out to us. And as long as they meet our criteria for who ketamine assisted psychotherapy is safe for, and who can benefit from it, as long as they meet that clinical criteria, then we can go into a conversation around their ability to pay for the treatment. And I don't have a specific set of criteria yet. But what Thank You Life has said is if a person meets our criteria and we feel that they should receive this scholarship, they will honor that at this point in their process. And so we're just going to approach it very individually. We don't have a specific set of criteria just yet. So they have to meet criteria for both from the financial perspective, and I don't have a specific numbers in mind, but also the clinical. We want to really make sure that we're going to provide this for people who can maximally benefit from it.
Great. Thank you very much. I had a couple of requests here to get Sherry your actual data analytics. So maybe that can be circulated, like, Tim Ferriss does show notes. These are not show notes, but whatever we'll call them.
Yes, happy. When we send out the recording, I can add sources for all of the data that I shared.
Thank you very much. So do any of the people, any of you have any experience in treating adolescent patients? I know I'm often getting calls from people with, my kid this or this challenge.
I can start that one, and then I don't know if either Mike or Marty have something to add. So under Anthea's current protocols, we do not cover ketamine-assisted therapy for adolescents, simply because we're taking a pretty conservative approach to safety and efficacy and wanting to make sure there's enough data before providing coverage. However, I do know of several ketamine clinics that are offering treatment for adolescents and reporting positive outcomes, but we just haven't seen enough to cover it as a benefit. And I don't know if anyone on this call knows Ben Sessa, but he's a great child and adolescent therapist who's done a lot of research on addiction in the psychedelic space. And recently I was speaking to him, and he highlighted that this is actually an interesting area of the future of psychedelic therapy. And I totally agree. We've been very focused on clinical trials with adults because it's important to get FDA approval, and we probably don't want to create too much noise to cloud that FDA approval. But there's no reason without proper adjustments to the protocol that we shouldn't look at these medicines for adolescents, because our youth are suffering from depression and anxiety and suicidal ideation in increasingly large numbers. I think the rate of suicide, this one, don't quote me on it, will not be in the show notes, but I think in the past 20 years, the rate of suicide in youth in America has doubled. So it's really crazy that it's at that rate. And I think this is a really interesting area for psychedelic therapy to explore.
Yeah, I would add that I'm not really aware of FDA trials that are treating adolescents, and I think there are a lot of issues with the scheduling for that. But what I will say is I actually believe Lykos is required to start conducting adolescent trials once they receive FDA approval. So that's going to be pretty interesting. And I think we know, the closer that you can treat to the traumatic event, we often can see better results. So I think it's definitely, as Sherry said, sort of an exciting, area is for research to develop. And, I think we know, we have quite a bit of evidence of adolescents using these compounds in recreational settings, and, minimal, I think, safety issues. Obviously there still are, but, if you now add in like the actual safety containers that we think about in the medical system, I think there's going to be a ton of promise on that front.
Great, thanks. There are hundreds of clinical research studies currently underway and proposed around psychedelics, looking at mechanism of action, comparing efficacy to other kinds of treatments, and across all types of psychedelics, molecules, treatment modalities. Given the limited budget to support research, what do you think are the most important studies that actually need to be done to make the case to third-party payers, insurance companies, and government agencies to cover these medicines and therapies? Can you point to anything specific that they need to see that might require additional studies, be them philanthropic or otherwise?
Yeah, I saw this question. The one thing I will say is it's really important to know what's possible in the near term event horizon, because there are lots of promising studies out there. There's lots of very promising new compounds or old compounds that are finally getting studied. But we know MDMA, ketamine's legal now. MDMA will be approved very likely by the end of this year and available next year. And psilocybin probably 2 years after that. Everything else, still has a pretty lengthy time frame to being available in our medical system. So I think that's one lens I would really, if I'm thinking about where I want my philanthropic dollars to go to help people in the near term, I would seriously be thinking about that, but obviously would never want, innovation and learning. And there's going to continue to be, I think, refinement of the tools available, that they're going to become more and more efficient with the more research we do. But those will take a lot of time. And, I'll go back to a lot of the research just isn't geared for insurance. I mean, that's just not how it's set up, right? So I think you'd probably be hard pressed to find any, university research going on that's really geared towards insurance adoption. I mean, when I think about it, the convincing ways that to make this sort of like a bulletproof case that insurance should be covering it is you really, you want to take people, you want to find out, like, will it reduce their ER admissions? Will it reduce, behavioral health psychiatric admissions? Will it, remove the need for medications and frequent, reducing therapeutic sessions over time? I mean, there's, and then also I think what's actually incredibly compelling case that I think, anecdotally I believe to be true, but I want to prove out with some of the pilots we're doing is, will it increase compliance with their other care? Because I think that's a huge issue for certainly government programs, Medicaid insurance companies is, are they seeing their primary care doctor? Are they following the other, care protocols that have been prescribed to them? Are they making healthier choices in their life? And I think there's a real opportunity with these types of medicines that, seem to be sort of these catalytic events to want to do better, feel better, make, real changes. Certainly that's the case when you're talking about people who are suicidal and now have this renewed, life that they want to engage in, that if we can start to show that they'll make those kinds of changes, I think insurance companies will be very, very interested in these therapeutic protocols.
Great. All right. Well, unfortunately, the part of this that I always hate is coming to the top of the hour, because there are still a lot more questions, and I'd love to continue the conversation. If I could just ask each of the panelists to, like, in 30 seconds or something, what's the one thing you want to make sure people walk away from this aware of? Let's start with Sherry, please.
Oh, mine is just, check in with yourself, and, see how you're doing. And if you're doing okay, take a few seconds to check in with someone you care about and ask how they're really doing. I think we need to do more of that.
Great. Thank you. Mike?
Yeah, I mean, I love that. And then I would also say, if, as leaders of employer groups, I think you wield enormous power. You have a lot of opportunity to be innovative where a lot of the medical system will lag. And I just encourage you to, think about the ways that you can be taking care of your employees and also forcing change in our systems.
Great. And Marnie?
I think that the most important thing to convey is that, these medicines are very, very powerful, and they have the potential to do wonders for people, both in their mental and overall health. And I think with that, we have to be just really cautious and careful and make sure that we are all looking at this from a place of hope and wonder, but also real care. And I think healthy skepticism is good here. And I think the data is important, and we need to keep moving forward with it. And in the meantime, be really careful and cautious with where we put our energy, and making sure we're delivering this care as carefully and thoughtfully as we can.
Great. Well, thank you so much to everyone who's joined today. Certainly thank you to Sherry, to Mike, to Marnie. This is one in a series of YPO-sponsored global conference calls or webinars, and all participants, anyone who signs up for one of the programs will be getting a recording. So there are some people who signed up who are not able to be on live today. Everyone here will also be getting a recording. So I encourage you, if you're interested in the space, to continue to sign up and learn more and get involved and make a difference, and check inside and make a difference and go forward and approach it wisely and with appropriate caution. So thank you, everyone. Hope you all have a great day. Thank you so much, Sherry, Mike, and Mark.
Yeah. Thank you.
Thank you.